Hi, I'm Ty Carroll. I'm an endocrinologist here at MCW, and I'm going to be talking about hyperthyroidism and what you need to know, especially if you are in internal medicine. Today, we're going to talk about the diagnosis and, in particular, the differential diagnosis of hyperthyroidism using biochemical testing and imaging. And then we'll talk about treatment and the different modalities that we have for hyperthyroidism. Hyperthyroidism is fairly common, 1 to 1.5% of the U.S. population, not nearly as common as hypothyroidism, which can affect, depending on if we're talking about subclinical hypothyroidism, up to 10% of the population. But hyperthyroidism is more common in women. The peak age in which it occurs depends on what the etiology of the hyperthyroidism is. And you should know that untreated hyperthyroidism can be deadly. And so it really needs timely diagnosis and treatment. And if a patient is going to be referred to endocrinology, they should be seen promptly. The signs and symptoms of hyperthyroidism are well known to many individuals and hopefully to this audience. And I realize that the signs are underneath the thing that says symptoms, and the symptoms are underneath the signs. But the symptoms of hyperthyroidism are sweating, weight loss, palpitations, fatigue. Signs include objective weight loss, goiter, tachycardia. You can have lid lag and other eye symptoms, or even a thyroid bruit. The initial biochemical evaluation of anybody who is suspected of having hyperthyroidism should start with the TSH. It's the single best test, and in individuals with overt hyperthyroidism, that TSH should be suppressed, meaning it's less than 0.1. The T4 and T3, in general, the free T3 assays are fine, and you can get free T4 and free T3. Those should be elevated in individuals with overt disease, and they're a good gauge of severity, but not always of symptoms. If we talk about subclinical hyperthyroidism, those are individuals who have a low TSH but have a normal T4 and T3. So once you have identified that a patient has a low TSH, especially if they have an elevated T4 or T3, then they should have differential diagnostic testing to figure out why they have hyperthyroidism. So we're going to talk about a couple of etiologies, although there are many really quite rare causes of hyperthyroidism. GD or Graves' disease. The other etiologies are toxic adenoma or toxic multinodular goiter. And then painless or silent thyroiditis is the other etiology that we'll talk about in some detail. So there are several different differential diagnostic tests. We're going to talk about the thyroid stimulating antibodies, TSI, or sometimes referred to as TRAB, TSH receptor antibodies. You can really just consider these all to be the same thing. They're the antibodies to look for Graves' disease. They are positive. They are the causative antibodies in Graves' disease. We'll also talk about radioactive iodine uptake in scans and ultrasound. So TSH receptor antibodies, or the thyroid stimulating immunoglobulins, and again, they're a little bit different antibodies. You can order either. The TSIs, or thyroid stimulating immunoglobulins, are a form of TSH receptor antibodies, and they're all great. They're relatively fast test results. They're less expensive than the other tests we're going to talk about, and they have a great sensitivity and specificity for diagnosing Graves' disease. Since Graves' disease is the most common cause of hyperthyroidism, really when you see somebody that has hyperthyroidism, you should get TSH receptor antibodies. If those are positive, that's diagnostic for Graves' disease. You don't need any other testing, and you can move on to treatment. If those antibodies are negative, then additional testing may be needed. So other antibodies like TPO antibodies or thyroglobulin antibodies, they are not helpful. But if you do see someone with hyperthyroidism, get the TSIs, and that, if they're positive, is the diagnosis of Graves' disease. So what about a radioactive iodine uptake and scan? So what is it? Well, it's really two different tests. It's an uptake, which is a percentage of how much of that iodine that was given is retained in the thyroid, usually 6 and 24 hours later. So they'll give patients a capsule of very weakly radioactive iodine, take a picture 6 hours later, have the patient come back the next day and take another picture. So remember that TSH stimulates uptake of iodine into the gland. So if the TSH is low, there shouldn't be uptake of iodine. So in an individual who doesn't have anything else stimulating the thyroid gland that has a low TSH, they won't have any iodine uptake. In Graves' disease, you have these antibodies that are stimulating the thyroid to pick up iodine. And so they have an inappropriately increased uptake. And in people who have autonomously functioning nodules, those nodules are working despite the fact that there's no TSH, and so those nodules pick up iodine as well. And then the scan part is an actual picture of where in the gland that iodine went. So if we're talking about a toxic multinodular goiter, this typically occurs in older patients. It often can be detected on exam. You can feel the nodules, but remember that just because a patient has a nodule doesn't mean that those nodules are overactive. On the iodine uptake and scan, these patients have what's characterized as a heterogeneous uptake. So they have multiple areas of what we call hot nodules and cold areas. So the hot nodules are nodules that are hyperfunctioning and pick up iodine, and the cold areas are the surrounding tissue that doesn't pick up iodine. Patients that have toxic multinodular goiters have negative TSI, or thyroid stimulating immunoglobulins or TSH receptor antibodies. Graves' disease is the most common cause of hyperthyroidism. These patients can have goiters of varying size. They don't have to have thyroid enlargement, but they can. They often can have proptosis and exophthalmos and Graves' dermopathy. These are really pathognomonic for Graves' disease. Without these things, Graves' disease is really indistinguishable from thyroiditis, which we'll talk about in just a minute. And then painless thyroiditis is an inflammatory process. So that results in destruction of the thyroid. And the thyroid normally has this preformed hormone sitting around. It's kind of like a warehouse of thyroid hormone. And if you inflame it and release some of that thyroid hormone, you actually get excess levels and you get thyroid toxicosis or hyperthyroidism. Patients can have a goiter in thyroiditis, but they don't have to. It's common in the postpartum period. The important thing is this is a self-limited disease. It does not need disease-specific treatment. And if we look at some representations of what iodine uptake and scans would look like in these different conditions, toxic multinodular goiter has multiple nodules or lumps that are overactive, and the rest of the gland is not taking up any iodine. If you look at Graves' disease in the lower left-hand corner, the entire gland takes up thyroid. If you have a solitary toxic nodule, that's just one big nodule that's overactive, the rest of the gland is suppressed. And in thyroiditis, the entire gland does not pick up any excess iodine. It's really dumping out the preformed thyroid hormone that's stored in the thyroid, but it's inflamed and not picking up iodine. So like I mentioned, Graves' disease and thyroiditis can be indistinguishable on exam or history. Also, the lab tests are often indistinguishable. The difference is that thyroiditis has a very, very low uptake, less than 2 or 3%, and Graves' disease has a normal or high uptake. So if the normal range of uptake is from about 20 to 35%, if a patient has a TSH that's 0 and they have a 20% uptake, that's not normal. You shouldn't be taking up that much iodine, and that's because those antibodies are stimulating the gland, and that's Graves' disease. So a word about thyroid ultrasound and differential diagnosis. It certainly is a valid method. It's mentioned in the guidelines for hyperthyroidism, but it really takes expertise. It takes color flow Doppler to distinguish increased flow versus destructive thyroiditis. And you really need quantitative Doppler evaluation. And for the most part, this is not done at most centers. And so I really recommend against the use of thyroid ultrasound in the differential diagnosis in most cases of hyperthyroidism. All right, moving on to treatment of hyperthyroidism. So in hyperthyroidism, we really have two goals. We have symptomatic relief. That's the use of beta blockers to decrease adrenergic symptoms. And then we have disease-specific therapies, antithyroid drugs, radioactive iodine, or thyroidectomy. So for symptomatic relief, you can use any beta blocker. Pick your favorite one, know the dosing, and give it. It doesn't make any difference what beta blocker you give. Every symptomatic patient should get beta blockers. In terms of symptomatic, we mean palpitations, tremor, anxiety, especially if patients are older. And any patient that has a resting heart rate of greater than 90 or has a history of cardiovascular disease should definitely be getting beta blocker for the treatment of their hyperthyroidism. Beta blocker only needs to be continued until the patient is rendered euthyroid on treatment, and then the beta blocker can be discontinued. All patients with overt hyperthyroidism, so those with a low TSH and elevated T4 and or T3, should receive therapy. And treatment with antithyroid drugs, radioactive iodine, or thyroidectomy is appropriate. Any of those modalities are appropriate. But one thing that should be noted is that we really give antithyroid drugs to slow down the thyroid prior to the other treatments in the vast majority of cases. We don't send patients who have very significant hyperthyroidism to the operating room because that increases their anesthesia risk. And with radioactive iodine, you can actually have a transient increase in thyroid levels after iodine therapy, so you don't want to give somebody who's already very hyperthyroid radioiodine treatment. We really give them antithyroid drugs to sort of cool them down, and then if we're going to use one of those other modalities, give it to them after that. So who are the patients that should get antithyroid drugs? Well, the guidelines list all these indications here. They really talk about patients who are likely or have a higher likelihood of remission in pregnancy, patients who don't have access to a high volume surgeon, a number of different indications. In reality, the vast majority of patients who have hyperthyroidism from Graves' disease or from toxic nodular disease get antithyroid drugs as the initial therapy. Certainly in Graves' disease, we'll talk about in a minute, but these patients have a certainly good possibility of having a remission and may only need a short course of methimazole therapy. Patients who shouldn't get antithyroid drugs are really just those who have already been on an antithyroid drug and had a major adverse reaction. Other than that, you can treat pretty much anybody with antithyroid drugs. So methimazole is the most commonly used therapy. PTU or propylthiouracil is also used in the first trimester of pregnancy and in thyroid storm, but methimazole is almost always the agent that we use in other situations. The starting dose is somewhere between 5 and 30 milligrams daily. Most patients need 10 to 15 milligrams daily, and methimazole can be given in a single daily dose unless that dosage is above about 30 milligrams. So don't give it as a 3 times dosed medication. It really is a single dose, even up to 30 milligrams a day. Before you start, you should have a baseline LFT and CBC, and then you should get a free T4 and T3 about 4 weeks after initiating therapy. Remember that TSH can stay suppressed for a number of months after you begin hyperthyroidism therapy. So this is one of the very few times that TSH is not a good indicator of thyroid function. That's right after the treatment of hyperthyroidism. Instead, we see a response in the T3 and T4. If those levels go down, then we can often wean the dose of methimazole 30 to 50%. So we generally start with a little bit higher dose, say 15 milligrams. If we see that the free T4 and T3 have gone down by 50%, we can wean off and probably go to 10 milligrams a day, recheck again after another month, and then continue to wean. And most patients can be maintained on a maintenance dose of 5 to 10 milligrams daily, sometimes even less. So the side effects from antithyroid drugs are uncommon. The two big ones that people worry about are agranulocytosis and hepatotoxicity. Agranulocytosis has a very low rate, and it's usually only on doses of 25 milligrams per day and higher, and that's for a prolonged period of time. Hepatotoxicity, methimazole, the hepatotoxicity is generally cholestatic. If you're using PTU, it's more hepatocellular. And those rates are actually also very uncommon. The reason we don't use PTU, other than the fact that it has to be dosed multiple times a day, is that it has a slightly increased risk of liver failure when compared with methimazole. But again, these are very rare occurrences. And there is no recommendation for routine monitoring of liver function tests or white blood cell count when patients are on therapy. Instead, if they develop symptoms, you should look for these complications. So, we generally treat people that have Graves' disease for 12 to 18 months. At the end of that course, assuming that they're euthyroid, we recheck their antibodies. If those antibodies are normal, we can wean off of the methimazole and look for a remission. We generally check thyroid function tests 1 month and then 3 to 6 months after we discontinue therapy. If patients have a recurrence, if their hyperthyroidism comes back, they can get radioactive iodine, they can get surgery, or they can go back on methimazole indefinitely. So if we look at the rate of relapse for individuals who have normal antibodies after a course of therapy, only about 20 to 30% of patients relapse. So that means 70 to 80% of patients who have a course of methimazole do not have relapse and can be off of medication. If those antibodies are still positive after that course of therapy, there's a very high risk of relapse, and we really don't wean people off if those antibodies are positive. So I mentioned about methimazole therapy and the complications. If patients develop a febrile illness or pharyngitis, we want to check a CBC and look for agranulocytosis. If they develop symptoms of liver disease, we check LFTs, but there's really no need for routine monitoring of LFTs or white blood cell count. Minor skin reactions are often just managed with antihistamines. If they have persistent minor side effects, we can switch them to PTU, radioactive iodine, or surgery as a modality for treatment. So from the guidelines, we should consider radioactive iodine more strongly in women who are considering pregnancy, but more than 6 months after radioactive iodine. We generally tell women that they shouldn't achieve a pregnancy for 6 to 12 months after iodine therapy. Again, if patients don't have access to a high volume center, if they have a contraindication to antithyroid drugs, then we should consider radioactive iodine. Individuals who shouldn't get radioactive iodine are women who are pregnant or lactating. If you desire a pregnancy in less than 6 months, you shouldn't get radioactive iodine. If you have a coexisting thyroid cancer, we shouldn't treat patients with radioactive iodine until after they've had surgery. And then after you get radioactive iodine, you need to have some radiation safety guidelines. So for about 3 or 4 days, they need to be separate from people most of the day. And then also in individuals who have thyroid eye disease, radioactive iodine has been shown that it may worsen the eye disease, and so those individuals shouldn't get radioactive iodine. Individuals that we should really strongly consider thyroidectomy for are women who are planning pregnancy in the next 6 months, people who have big goiters or have thyroid cancer, individuals who have severe thyroid eye disease. We can certainly consider those individuals for surgery as well. People who shouldn't get thyroidectomy, if you have a lot of comorbidities, if you don't have a good surgeon around. Obviously, if a woman is pregnant, it's a relative contraindication, but surgery in the second trimester is safe, although it's not without risk. There's about a 5% risk of preterm labor with surgery in the second trimester. And then finally, thyroiditis. So as I said, thyroiditis is self-limited. It only needs symptomatic treatment, so beta blockers. We don't use antithyroid drugs. We certainly don't give iodine or do surgery on these individuals, and they get better over the course of several weeks to several months. We generally monitor thyroid function about every month and make sure that their hyperthyroidism has resolved. Many of these patients will undergo a transient hypothyroid phase. So they'll get hypothyroid for a little bit, but then over the course of several weeks to several months, they will recover to normal thyroid function. About 85% of patients who have that hypothyroid phase go on to have normal thyroid function. Thank you for your attention, and I hope that you enjoyed this discussion of hyperthyroidism.